With a mind map on lung compliance, we'll try our best and brainstorm and bring back everything that we remember on um, the determinants of compliance, lung compliance in general, chest wall compliance and factors affecting it, and also the physiological basis of respiratory failure in neonatal respiratory distress syndrome. All right, so when it comes to respiratory compliance or lung compliance, always think of the Hooke's law analogy. So Hooke's law, you know, it has to do with the the Hooke's law states that the force applied to a string-like structure is directly proportional to its extension, as long as it remains within the elastic limit. So if you take it the other way around, the change in length of the length is directly proportional to the force. But then if you have to equate it, there would definitely be an elastic constant which has to do with the stiffness. So in the lungs, actually applies to the lung tissue and alveoli, which behave like elastic tissues, and the lungs expand and contract due to elastic properties of the alveoli and connective tissue. So when you take the elastic constant K, it has to do with the changing the length over changing force. So definitely the unit of K will be meters per Newton. All right. So that is it. So stretching force is directly proportional to the extension. And when the elastic limit is reached, then the curve starts to curve. The compliance has to do with volume and pressure, where volume is proportional to the pressure. So compliance will be equal to or is equal to changing the volume over changing pressure. So compliance is directly proportional to changing volume, but inversely proportional to changing pressure. And the unit of compliance is liters per centimeter H2. All right. So the lung as an elastic tissue, always remember the rule of elastin and its effect on surface tension, and lung volumes relation with pulmonary pressure. So the lung acts as an elastic tissue, and elastic behavior of the lungs is caused by the tissue elastic forces, which is equal to 1/3 of the total lung elasticity, and the fluid air surface tension elastic forces in the alveoli is about 2/3 of the total lung elasticity. So the elastic behavior is, however, nonlinear, and elasticity decreases with lung volume. The lung compliance varies inversely as elasticity. And when it comes to the pediatrics, the pediatric lung has more elasticity and hence less compliance. So get it, elasticity inversely proportional to compliance. So the adult lung has less elasticity and has more compliance. Okay, so that is the main thing over here. Remember, compliance has to do with changing or delta V over delta P, changing volume over changing pressure. So if you have a pressure, let's say around 1,000, you have a volume around 1,000, changing volume is 1,000, and you have changing pressure 5 centimeter H2, then the compliance will be 1,000 over 5, which is 200 mils per cm H2. The lung compliance basically has to do with the change in lung volume per unit change in descending pressure. So the descending pressure is the transpulmonary pressure or the transpleural pressure, and the compliance is the gradient of curve of lung volume versus the intrapleural pressure curve. And lung compliance is a measure of the distensibility or stretchability of the lungs, ability of the lungs to stretch and expand. High compliance has to do with easy to inflate lungs, easily distensible, but low compliance has to do with stiff lungs, and extra work is required to bring in a normal volume of air. Right. So the features of lung inflation curve. The curve does not start from zero volume. The residual volume exists because small airways begin to close below a certain critical lung volume, and the curve is non-linear. Gradient of inspiratory curve is lower at the lowest lung inflation and at high lung inflation, so difficult to inflate the lung at the start and also at the end, and easier midway. Inflation hysteresis. Actually, inspiratory length follow a different tracing from expiratory length, and with the high versus low lung compliance, the conditions increasing compliance or compliant lung has to do with natural aging, conditions like emphysema due to loss of the alveoli and elastic tissue. Okay, we need to pour elastic recoil, hence difficulty in exhaling hair, and also conditions decreasing compliance like stiffer lung in restrictive lung disorders like pulmonary fibrosis, hydrothorax, pneumothorax, RDS, ARDS, abdominal insufflation, atelectasis. So that is the main thing. So when it comes to problems of high lung compliance and problems with of low lung compliance, there are several. With low lung compliance, so with high lung compliance, you can think of several problems. High compliance, like I said, has to do with the lungs being able to expand easily, but have poor elastic recoil, making expiration very difficult. And with this, the causes and associated conditions include emphysema, COPD, where there is destruction of elastic fibers causing overinflation. Aging too, like I said, has to do with the loss of lung elasticity with age. Surfactant excess. This is very rare, but it reduces alveolar surface tension too much. And the consequences in this is that it leads to air trapping and hyperinflation, increased residual volume, and increased work of breathing, difficulty exhaling due to reduced recoil, and also hypoxia, where there is poor ventilation perfusion mismatch. Alright, well, when it comes to problems with low lung compliance, the low lung compliance means the lungs are stiff and require more effort to expand, and the causes has to do with pulmonary fibrosis, where scar tissue replaces elastic tissue. ARDS, acute respiratory distress syndrome, where inflammatory damage leads to fluid-filled alveoli. And neonatal respiratory distress syndrome, NRDS, surfactant deficiency in premature babies, depicted over here, and pulmonary edema, where fluid accumulation increases stiffness. When it comes to the clinical consequences, it leads to increased work of breathing, where more effort is needed to inflate the lungs, and shallow, rapid breathing to compensate for reduced lung expansion. Hypoxia or respiratory failure due to poor oxygen exchange with stiff alveoli. Right, so there are so many things involved over here. So again, remember that poor compliance is seen at low volumes because of difficulty with initial lung inflation, and high volumes because of the limit of chest wall expansion. Breast compliance in the mid expansion range. Application is in PEP in mechanical ventilation. Alright, so when it comes to the regional differences in lung compliance and inflation, in that upright position, realize that the transpulmonary pressure, the pleural pressure, alveolar pressure are all different. at the various stages too. So at um, FRC, the transpulmonary pressure is greatest at the apex. Starting alveolar volume is greatest at the apex than at the base, and the lung is less compliant, that's stiffer at the apex. The original lung ventilation is greatest at the base. Original lung ventilation is equal to change in volume per unit resting volume. So Laplace law states that pressure inside a spherical structure is directly proportional to the tension in the wall and inversely proportional to the radius of the sphere. That is P is equal to 2T over R. And you know the thickness of the thickness indicates surface tension, and without surfactant the surface tension in both the alveoli is the same. In several alveoli are the same. The greater pressure is required to keep small alveoli open. A small alveoli tends to empty into the larger ones, but with surfactant the surface tension reduced in the alveoli, the small alveoli, because of the pressure distending both alveoli or several alveoli and making it almost the same. The alveoli are stabilized and the tendency for small alveoli to empty into larger ones is reduced. So when it comes to surface tension, then Laplace law, the model is a balloon. So the force acting on the surface when inflated, surface tension acts to collapse the lungs. So remember the Laplace law, which is 2mt is equal to 2pr, or P, the pressure is equal to 2 over T, that's the tension, over R, the radius of the sphere, the alveoli. So the surface tension varies with area or radius, and the surface tension rises as area gets better, and the surface tension falls as area gets smaller. Okay, so when it comes to air and saline lung inflation, comparing that to the lung volume change and the pleural pressure. So the lung inflation can be studied by inflating the lungs with air or saline while measuring the lung volume changes against pleural pressure. So the differences between these methods highlights the role of surface tension in lung mechanics. So remember the factors: inflation, curve shape, and compliance, and surface tension effects. So when you take inflation curve shape, in air inflation there is hysteresis, which is difference in inflation and deflation curves, and also in saline inflation there is minimal hysteresis, which, like I said, is the difference in inflation and deflation curves. With compliance in air inflation, it's lower as more pressure is needed, and in saline inflation it's higher as easier inflation occurs. With surface tension effects, in air inflation, it's present due to air liquid interface in alveoli, but with salt inflation it's absent since the saline eliminates the air liquid interface. When it comes to lung volume for given pressure, it's lower for air inflation and higher for saline inflation. Alright, so when plotting the lung volume against pleural pressure, we realize that air inflated lungs shows hysteresis, and more pressure is needed to inflate than to deflate due to surface tension from the alveolar fluid. And with saline inflated lungs, like I said, the inflates and deflates along nearly the same pathway, and no air liquid interface, so no surface tension forces, and the lungs are more compliant, they inflate with less pressure. But why does the saline inflation show higher compliance? Because the saline removes the air liquid interface, like I said, eliminating the surface tension. This proves that the alveoli surface tension significantly affects lung compliance. And with the clinical implications, surfactant therapy, for example, in neonatal respiratory distress syndrome, reduces surface tension, making the air inflate easier. And with pulmonary edema, it increases surface tension, making breathing harder, and making low compliance like air inflation. All right. So when it comes to the air-filled inflation, lies to the right of the saline-filled inflation. Greater transpulmonary pressures are required to expand air-filled lungs than saline-filled lungs, and transpulmonary pressure is required to expand air-filled lung. There's normal lung, which is 3 times the pressure to expand saline-filled lung. The saline inflation has a steeper slope than the air inflation. Saline inflation is more compliant than air inflation, which is easier to inflict saline-filled lungs. And with the mechanism, by adding saline solution, there is no interface between air and alveolar lung, and the surface tension forces were removed. So air inflation causes a large hysteresis, and saline inflation causes little hysteresis. So surface tension is surfactant. Remember that surface tension acts to collapse the lungs, and the surface tension decreases the surface. Surfactant decreases the surface tension, and surfactant is a complex mixture of several lipids, proteins, and glycoproteins like the phospholipids, palmitoyl phosphatidylcholine, which are all phospholipids too, and also surfactant, apoproteins, cholesterol, calcium. Surfactant is found in and secreted by the type 2 alveolar cells, and of course it lines the alveoli, has a short half-life, has to be produced all the time. When it comes to the clinical application, in neonatal respiratory distress syndrome, like I said, the fetal surfactant synthesis occurs between 24 weeks and 35 weeks. And how to determine whether a fetal lung is mature? Generally, lectin sphygmomyelin ratio. So lectin sphygmomyelin ratio greater than 2:1 in amniotic fluid reflects the mature lung levels of surfactants, and other tests like the surfactant albumin ratio less than 35 indicates immature lungs, and between 35 to 55 is indeterminate, and more than 55 indicates mature surfactant production. When it comes to premature neonates, they may suffer respiratory distress. So let's look at a case over here. So this case has to do with a neonate born at 33 weeks gestation. Predict the maturity states of the lungs, as the lungs likely to be immature, and then why? Think of the circular phase of the lung development, which is complete after 35 weeks. But this case, the neonate is at 33 weeks gestation. And what laboratory test will you perform to confirm your suspicions? The lectin, the lecithin sphygmomyelin ratio. If less than 2, the lungs are immature. Also, comment on the effects of preterm delivery on neonatal respiratory function. Alright, so with this particular case, know that you have to predict the maturity state of the lungs, and like I said, the lung maturity is likely to be incomplete at 33 weeks of gestation. The lungs develop in several stages. The pseudoglandular stage from 5 to 17 weeks gestation, the canalicular stage from 16 to 35 weeks, the circular stage from 24 to 36 weeks, and the alveolar stage from 36 weeks to early childhood. So at 33 weeks, the neonate is at the circular phase where the sac-like structures are forming but are not fully mature. So the surfactants production by type 2 pneumocytes increases significantly after 35 weeks, which is crucial for reducing alveolar surface tension and preventing neonatal respiratory distress syndrome. So since this baby is born preterm before 37 weeks, the lungs are likely mature, increasing the risk of neonatal respiratory distress syndrome. So what laboratory test is it to confirm the lung maturity? The Leston sphingomyelin ratio is a test that is performed on the amniotic fluid to assess vital lung maturation. And the principle is that the lecithin, which is a phosphatidylcholine, is a major component of pulmonary surfactant, and sphingomyelin remains constant in amniotic fluid throughout pregnancy. So as the surfactant production increases, the lecithin sphingomyelin ratio rises. So the interpretation is simple. The LS ratio less than 2 indicates that the lungs are immature with a high risk of neonatal respiratory distress syndrome, and the LS ratio more than 2 indicates that the lungs, even at 2 or more than 2, indicates that the lungs are mature with a lower risk of neonatal respiratory distress syndrome. So what is the effect of preterm delivery on neonatal respiratory function? And it's simple. Preterm neonates often develop neonatal respiratory distress syndrome due to surfactant deficiency. So the pathophysiology is very, very simple. Lack of surfactant, increased alveolar surface tension, therefore leading to alveolar collapse, that's atelectasis, and hypoxemia and lung failure follows. So the clinical features of neonatal respiratory distress syndrome is that tachypnea as to do with rapid breathing, grunting, nasal flaring, intercostal retraction, cyanosis with low oxygen saturation. And with the management, we deal with antenatal corticosteroids, which, for example, betamethasone, dexamethasone to the mother before preterm, which stimulates surfactant production, and exogenous surfactant replacement therapy for the neonate if neonatal respiratory distress syndrome develops. So oxygen therapy and CPAP with continuous positive airway pressure to prevent alveolar collapse. So in summary, a 33-week neonate is at high risk of respiratory complications due to immature lungs, and lecithin sphingomyelin test can assess the lung maturity. Like I said, if it is less than 2, it's immature, the lungs are immature. If it is 2 or more, then the lungs are mature and with a lower risk of neonatal respiratory distress syndrome. And this guards the need for respiratory support and surfactant therapy if it is less than 2. Alright. So low levels of surfactant, increased alveolar tension, alveolar collapse, impaired pulmonary gas exchange, hypoxemia, decreased lung compliance, increasing work of breathing, no need to get tired breathing, will be reduced alveolar minute ventilation, reduced pulmonary exchange, hypoxemia, if there is no intervention, lead to death. But how could you have artificially matured the lungs? Like I said, dexamethasone, betamethasone, you administer steroids to the mother 48 hours prior to delivery, and this promotes the proliferation or maturation of the type 2 pneumocytes. And how will you manage this neonates? Of course, you can administer surfactants or mechanically ventilate this, or the CPAP I talked about. What is the causes of hypoxemia in neonatal respiratory distress syndrome? In mature neonates exhibits atelectasis, which is alveolar collapse, difficulty in reinflation or reinflating the lungs, a result of decreased lung compliance or increased work of breathing, vacuum mismatch, increased risk of non-cardiogenic pulmonary edema, and also hypoxemia. With some few notes on neonatal respiratory distress syndrome, it's a respiratory distress that occurs within few hours after birth, occurring in about 2% of all live birth. There's an increased incidence in premature neonates due to deficiency in surfactants, and it leads to decreased lung compliance with stiff lungs and difficulty in respiration. As with the therapy, there is surfactant replacement, artificial ventilation, ECMO, and with the pulmonary surfactant, it may be synthetic or derived from animal lungs. With fetal lung maturation, how do you artificially mature the lungs before delivery? I said you administer steroids like betamethasone or dexamethasone to the mother, and the steroids promote proliferation and maturation of the type 2 pneumocytes. The steroids are given to the mother at least 12 hours, preferably 48 hours prior to delivery, to significantly enhance neonatal pulmonary maturation. When it comes to chest wall compliance, there's a change in chest wall volume per unit change in transmural pressure. The transmural pressure is equal to the intrapleural pressure minus atmospheric pressure. Has to do with the positive transmural pressures. That is, if you have the intramural pressure more than the atmospheric pressure. For example, for lungs, the transmural pressure is equal to the transpulmonary pressure. And with the compliance of the lungs and the thorax at functional residual capacity, or FRC, the thoracic cage has elastic elements, so the chest wall elastic properties makes it spring out or expand at FRC. So the lung elastic properties makes it recoil collapse out at the FRC. So at FRC, there's a equilibrium. Chest wall compliance and lung compliance are equal and opposite. So the combined compliance of the lung and thorax is calculated as an inverse of the total compliance, or 1 over total compliance is equal to an inverse of the lung compliance plus an inverse in the compliance of the chest wall. So 1 over compliance of lungs plus 1 over compliance of chest wall. So the total respiratory compliance is lower than either chest wall compliance or lung compliance. And the greater pressure change is required to produce a given volume change in the combined thoracic and lung system than either. So when it comes to chest wall compliance in disease, the actual reduction in chest wall compliance, stiff chest wall, I think of chest wall deformities like kyphoscoliosis, and functional reduction in chest wall compliance due to displacement effect of abdomen on diaphragm, like pregnancy and ascites. Alright, so we'll continue with airway resistance later.